I'm going to talk to you right now about valve replacement choices, and this is something that you're going to be dealing with every day, and you really need to make sure that you have very frank discussions with your patients and their families about valve replacement choices before they go to sleep. I always tell the patient, you can change your mind at any time until you go to sleep, and after that, I'm not going to wake you up to talk to you about it. So welcome you all to Bootcamp. Hope you're having a good time. Hufnagel implanted the first valve, and this was his design with a valve that was implanted actually in the descending aorta. And then Starr developed the Starr-Edwards valve implanted in the 60s. There were various iterations that were less successful. This disc valve had pretty high gradients, but it also had a dissolving disc that ended up in the carotid sometimes. And when the silastic ball of the Starr valve chipped away a little bit, they decided to put Dacron over the struts, and that didn't work out real well. But over the years, we haven't perfected things. We haven't come up with the perfect valve. Obviously, that perfect valve was created a long time ago, but not by man. So we're still working on it, but we're making improvements. And so the aortic valve choices, there are several choices here. We're going to talk about several of these. Mitral valve choices as well. And more and more, the standard for the mechanical valves has become the bileaflet valve. And here you see different iterations: the St. Jude Standard, the St. Jude Regent, the Onyx valve, the Carbometics valve, and then valve conduits with various valves implanted. There was a paper recently showing the 40-year data of the Starr-Edwards valve, calling it the gold standard for valve replacement. I think some people don't believe that now, but the bileaflet valve by far has become the most popular valve implanted for mechanical valves. And here you see the valve hemodynamics, the differences between a ball and cage valve, a tilting disc valve, and a bileaflet valve. And you can see here the bileaflet valves have much better hemodynamic flow patterns, and you can see there's little washing jets built in at the hinge points to try to decrease the amount of stasis and the risk of thrombus there. But the Achilles heel of the mechanical valve has always been thrombus, and so patients are required to take warfarin, which is rat bait or similar, and it's a pill they have to take every day. There's multiple complications besides just bleeding, but the bleeding and the thrombosis have been the Achilles heel. So tissue valves came along in the 70s, and when they first started, people thought that was the panacea. They finally created the perfect valve that they could implant. There was no rejection, but over time, several of these tissue valves were brought to market, and the hemodynamic profile was excellent. Here you see the pericardial valve, the porcine valve. This is made of bovine pericardium fashioned into 3 leaflets. The porcine valve is made of porcine valve leaflets put together in a size match. And you can see the hemodynamic profile was excellent. But over time, we found that these valves did deteriorate and did start to wear out and break down. Early on, there were statements by Enescu and others saying that these valves will last forever and you should put them in everyone, and then all of a sudden we started seeing reports of thousands of valves being explanted. Over time, Jameson and several others found that the structural valve deterioration rates were different with different age groups. And so we started seeing that the younger you were, the earlier you started having problems with structural valve deterioration. And so that kind of changed the thinking, changed the paradigm. Over time, these different age groups would wear out with different rates. The other thing we found is that a lot of these valves were calcifying over time, and the very early valves that had high pressure fixation, there were hinge points in the valve tissues that would bear the stress, and when they were prepared under high pressure fixation, they were more likely to break at the hinge points. They also had no anti-calcification treatment. Second generations had low pressure or zero pressure fixation, and anti-calcification treatments, and now third-generation valves are usually fixed under physiologic fixation pressures and have newer anti-calcification treatments, which have really caused us to have better outcomes over time. So in the past, people used to say, and I still hear cardiologists tell patients now, and some surgeons tell patients, if you get a tissue valve, it's only going to last 7 years, and then you're going to have it taken out, and that's not exactly true. When we quote studies that say that within 10 years you have so much percentage of a chance of having a valve replaced, a lot of people interpret that to mean at 10 years they're going to have their valve replaced. So you have to be very careful about the way you talk to your patients about the valve replacements. So this study showed that over 100% of, not over 100%, 100% of patients who got their valve when they were in their 70s were still working at 14 years, almost 90% in patients 61 to 70 years old. So with newer generation valves over the last couple decades, we've seen a change in the paradigm, and this study from the STS database showed that back in 1995, almost 60% of the valves being implanted in the aortic valve position were mechanical valves, and about a third were tissue valves. And over time, that's actually reversed, even in a 6-year period, where 36% were mechanical and 60% were tissue valves. This was in 2001. This was long before TAVR. So a lot of people were saying that the idea of a valve-in-valve is the reason for the paradigm shift, but this actually occurred earlier. Some of it is because patients were getting older and sicker and were getting more tissue valves. A lot of it was due to recognition that the tissue valves had better outcomes than the previous generation valves. This study more recently shows that the number of tissue valves going in is much higher. The number of mechanical valves is slightly decreasing. And there is the option of a valve-in-valve in select patients. It's not the standard of care yet. It may be soon, and it is. But there are some problems and complications. So it's not fair to tell a patient that you need to choose a tissue valve because if it fails, we can just put a valve-in-valve. There's a lot of other variations in the size of the valve you put in and the type of valve you put in that may make it easier or harder. But a valve-in-valve is an option, and that should be discussed with your patient when you're deciding valve types. You can't do a valve-in-valve in a mechanical valve, but you can do it in a lot of tissue valves. You also have to take into account the size of the valve you're putting in when you're doing the original operation to make it more feasible to do a valve-in-valve later. So what's the basis of how we make our decisions on which valves to put in? Early on, this VA randomized trial was done looking at 575 men. Mean age was 59, and back then they were using Bjork-Shiley valves and Hancock porcine valves. We have different valves now. But in that study, there was no statistical difference in the survival, the probability of death in patients either getting aortic valves or mitral valves. So the death rates were the same, the survival rates were the same. But what they found was that while the probability of any valve-related complications was similar in both the mechanical and bioprosthetic valves in the aortic valve and in the mitral valve group, when they looked at the probability of bleeding, there was a higher, statistically significantly higher bleeding rate in mechanical valves in both aortic valve and mitral valve position, but they didn't eliminate the bleeding risk in bioprosthetic valves. When they looked at the probability of structural valve failure, they saw that the tissue valves failed at a higher rate, and the mechanical valves almost never failed from a structural means. More recently, this study showed 30-year outcomes of AVR in mechanical and tissue valves. Dr. Reardon was probably involved in some of these patients at Texas Heart Institute. But this study showed their survival rate in mechanical and tissue valves was the same or similar over 30 years in patients that were less than 60 years old at the time they got their valves. And so we started thinking that maybe it's reasonable to put these valves, tissue valves, in younger patients. Another study came out just in 2008 from Mayo Clinic showing that the survival rate was actually much better in younger patients that had mechanical valves in the aortic position. Criticism of the study was that the early mortality was much higher in the tissue valves, and when you look at this study, this was a non-matched study. It was a retrospective study, non-matched, and the criticism is that these patients getting tissue valves were probably older and sicker, because there's no reason that someone should die early because of a tissue valve instead of a mechanical valve. Dave Adams looked at the New York State Registry. In this patient population of patients aged 50 to 69 that had aortic valve replacements, he saw over 15 years, they showed that there was no difference in survival in the mechanical or the tissue valve group. This was also a retrospective analysis, but it was propensity matched. And just like the VA study, they saw no difference in patients' survival, in the stroke risk. There was no difference, but they did see a higher number of reoperations in the tissue valve. But if you look at the mechanical valve rates, telling a patient that if you get a mechanical valve, you're not going to need a reoperation is just not true. They do get reoperated on for various reasons. We'll talk about that in a minute. If you look at the major bleeding, again, mechanical valves, much higher risk of bleeding, but the tissue valves are not free from hemorrhagic complications. So if we look at the choice of prosthesis for aortic valve, we question, does the choice affect survival? And in the older randomized trials, it didn't. In the newer retrospective studies, it didn't. And several meta-analyses have shown no difference in survival. So the survival is equivalent, which means the choice of the valve type should be based on quality of life if you're talking about someone in their mid-50s to 70. Anybody who's over 70, I think you should really push to have a tissue valve because their rates of structural valve deterioration are so much lower, and the guidelines have actually shifted downward from an age of 70 down to 65 more recently. But if we look at quality of life after a mechanical valve, some people say, well, you just take a pill every day, and that's not exactly true. You do have to take a pill every day, and sometimes that can be hard for a lot of these older patients, but you also have to have blood tests. You may have to go to Coumadin Clinic or the home PT monitoring. There are drug interactions, and I always have to tell my patients, anytime you get on antibiotics, you have to call your cardiologist or your Coumadin Clinic and let them know you started antibiotics because you're wiping out all of the vitamin K in your gut. Patients often are on NSAIDs. They're on multiple other medications that can have drug interactions. Food choices are important to keep in mind that when they change to a leafy green diet, they need to let their cardiologist know. Activity precautions are important. If you have to reverse the Coumadin, emergent surgery, trauma, elective surgery, you may have to bridge with Lovenox. You might put your valve at risk for thrombosis while you're recovering. And then travel. You need access to labs, pharmacies. Lots of patients here in Texas talk about when they're down at the ranch, they can't get a Coumadin clinic. So that's important. And then the other thing, stop that damn clicking. The patients, some patients are really bothered by this. Of course, they don't want to stop the clicking, but they would like to have the clicking stop. There's always that anxiety about, is this a ticking time bomb? There's the risk of valve thrombosis, major bleeding, thromboembolism, stroke. Those things happen suddenly, whereas structural valve deterioration happens more gradually. Freedom from reoperation isn't 100% with a mechanical valve. And then there's special situations, and then you have to ask, how long are you going to live? Are you going to outlive your valve? So the quality of life after a tissue valve is a little different. Take an aspirin a day. There is a risk of reoperation, anywhere from 12 to 30% over 15 years. Doesn't mean at 15 years that you're going to drop off the face of the earth, but about 70 to 88% may not need a reoperation, and will you outlive the risk of a redo? Also, the risk of reop mortality is about 5 to 8%, but if you have a mechanical valve and you have sudden acute bleeding, The risk of a bleeding episode with a mechanical valve is about 7.5%. The risk of stroke mortality is about 8.5%. And if you have valve thrombosis of a mechanical valve, the risk of dying is about 60 to 80%. So this study showed the patients who had an aortic valve replacement with a mechanical valve, and these were all comers, and it showed a 15-year follow-up. And this area under the curve is the number of valve-related deaths. The patients who had reoperations for endocarditis, which is about 1% per patient year, and then the major thromboembolic complications, major bleeding complications. So if you look at all the complications and deaths that are related to the valve, there were only 42% of patients still living free of a major complication or dying at 15 years, which is what you talk about your cutoff for a structural valve deterioration risk. You take into account other deaths like house fires, car wrecks, and 23% of the patients are still alive 15 years later to reap the rewards of avoiding a tissue valve. So this study from the Cleveland Clinic looked at the life expectancy of how long you're going to what percentage have to have a an explant for structural valve deterioration during their remaining lifetime. And if you look in the 50-year-old range, up to 10%, but as you get older, there's much less likelihood that you'll ever need a valve explanted. So this is size does matter. The size of the valve matters. And this study from the Cleveland Clinic, where they popularized the size doesn't matter concept, actually showed that with tissue valves, the degree of structural valve deterioration correlates very well with the AV gradients. So if your gradients are high, you're going to have a higher risk of structural valve deterioration, and that works with TAVRs as well as open tissue valves. So we used to enlarge the aortic root. About 20% of my patients used to get an aortic root enlargement. Nowadays, we can use increased orifice to annulus ratio valves, which increase the EOA and the gradients. So the St. Jude Regent valve, as a mechanical valve, has a much bigger orifice area than the St. Jude standard. The trifecta valve has a large opening area, and most of the time we see gradients in the single digits, even with the small size valves. You can use stentless valves. This Percival valve also has a much higher orifice to annulus ratio. Other options, the Ross procedure, apicoaortic conduits. Dr. Reardon's going to touch on TAVR in his aortic valve talk, and other options for transmitral valve replacement. These valves are going to be a little more complex, but they're coming down the pike, and we need to know how to do them. So the selection of AVR types is dependent on several patient characteristics, and if you look at age, remember the autograft, the Ross procedure will grow with the patient, so that's used mainly in kids now. A homograft may calcify and may need to be replaced, so keep that in mind. It's not a perfect valve. Coumadin is teratogenic, so think about the patient's age and whether they're going to, whether a female is going to be wanting to have kids. And the tissue valve, structural valve deterioration is age dependent. The etiology of the valve is important for choosing which valve you're going to choose, and medical conditions of the patient as well as patient prosthesis mismatch.